Very good evening. It's my pleasure to welcome you all to the second part of the magazine edition of Anesthesia Connect by ISA Kerala State Chapter, our weekly virtual CME series. Last week's session received a wonderful participation, and today we continue that momentum with short, meaningful, and thought provoking topics. As part of today's program, we also have ISA Kerala Kahoot Quiz. Our quiz masters are ready with engaging questions and exciting cash prizes. So I request all of you to participate and make it a fun learning experience. I also I request everyone to follow the ISA Kerala Instagram page. We are currently live on a Facebook page and YouTube channel. And very soon, our sessions will also be streamed in our Instagram channel. AnaesthesiaCONNECT has become a platform that keeps us updated, connected, and inspired as a professional community. I sincerely thank our academic team guided by Dr. Sanish PJ, our speakers, Dr. Ashu Mathai, Dr. Baburaj, Dr. Sajish Ji, and Dr. Devi Padmakumar and team, and Dr. Remya as the quizmaster, and our moderators, Dr. Rajesh Shamsi and Dr. Vijish Venugopal for their efforts. I extend my sincere thanks to all the members for joining us consistently every Saturday. I hope today's session adds value to your practice and strengthen our shared commitment to learning and excellence. Thank you all, and let's begin the program. I hand over the stage to Dr. Ashu Mathai.
Good evening and welcome to the next edition of RISKScripts, where we decode anesthesia risk scores. In our last session, we took a closer look at the ASAPS classification, that familiar 1 to 6 scale we all use in seconds. But we learned how much importance it carries in our clinical day-to-day practice. We learned that the ASA scoring isn't just about ticking a box. It's about communicating the patient's result and setting the stage for risk discussion. Now that we've laid the foundation with the ASA score, let's zoom in to one of the most critical aspects of peri-op evaluation, which is the cardiac risk assessment. Now, all of us would have faced that familiar question, is this patient fit for surgery from a cardiac standpoint? And so let's look at how structured tools like the RCRI and the modern NSQIP helps us answer that question effectively, particularly in someone with multiple comorbs or limited exercise tolerance. Now, before we dive in, here's a quick question for you. When you see a patient labeled as ASA2 with essential hypertension, posted for a laparoscopic cholecystectomy, how do you estimate the cardiac risk? Do drop in your thoughts in the chat box below and let's see what most of us prioritize. Is it ECG changes? Is it functional capacity? Or is it a scoring like the RCRI? While you post in your answers, let's listen to Dr. Nimi Raju, Assistant Professor, Believers Church Medical College Hospital, to learn more about cardiac risk assessment. Over to Dr. Nimi.
Good evening, everyone. In continuation with RISKscript, today I will discuss the cardiac scoring systems. We all know that cardiovascular complications, they contribute to approximately 50% of perioperative mortality, of which perioperative myocardial injury is an important complication seen in around 20% of patients. Therefore, the need of cardiac scoring systems. We have numerous models, scores, tools, including functional capacity and cardiac biochemical markers to assess these patients who come for a non-cardiac surgery, of which we will discuss the scoring systems available. Now, taking a case scenario, we have an elderly patient who is posted for an elective right hemicolectomy. He's a known diabetic and hypertensive on medications, not insulin. He's had a prior NSTMI, for which he is on aspirin, beta blocker, and statin. Initially, we need to identify any red flags like an angina at rest, a decompensated heart failure, arrhythmia, or any valvular disease. If there are no such signs, it is safe to proceed for a functional assessment, which is the first step in evaluation of these patients. Now, what we normally analyze the METs, it is more of an unstructured patient interview. Some vague questions are usually asked. Okay. In a situation when this is not clear, we need to go for a more structured questionnaire in the form of a DASI questionnaire. Though it is complex, it lists out an elaborate number of activities that the patients are able to do, and METs can be calculated. A more specific value of METs can be obtained from this questionnaire. So those who have a score of less than 34 are considered at a high risk of surgery. To put this into this patient, suppose that this patient can climb just a flight of stairs and he gets breathless on moderate household activity. He definitely has a poor functional capacity, which means his METs is less than 4. And to be more specific, as calculated by the DASI questionnaire, his METs would be 3.07. Now, following the functional assessment, we now move on to his cardiac risk assessment. The most commonly available one is the RCRI. We all know it contains 6 components, okay? And it estimates the risk of major cardiac events only. It is a simple bedside score that can be used. It has been extensively studied and validated. Now put this tool to this patient. He has a history of CAD. He is not a patient with CKD with a high creatinine value. There's no history of insulin use, and this is a high-risk surgery. So his RCRI score will be 2, which means he's at an intermediate risk. That is a 6% risk of developing major adverse cardiac events. Now, like I said, RCI will only help us to estimate the risk. Now, how do we quantify this risk? Will be with the help of the NSQIP risk calculator, which calculated for this patient has estimated a 30-day cardiac event probability of 6 to 8%. So the initial risks calculator was the MICA, which came in 2011. That had just 5 components. Again, only the major cardiac complication was the outcome studied. Then the ACS NSQIP risk calculator, it's a more extensive tool which has 21 components. So this actually quantifies post-operative outcomes, including cardiac, pulmonary, renal, and even the 30-day mortality compared to the RCRI, which only estimates cardiac events. The only issue with this is that it's a web-based tool, data-driven statistical model. Okay, so it is time consuming. However, it is comprehensive and it is patient and procedure specific. A lot of factors are considered when this tool is being applied. The next question is, we have calculated the risk, or we have estimated the risk, and we have quantified the risk for this patient. Now, what should we order? Like we all know, ECG is routine for the elderly. Echo should ideally be done only if there are symptoms missing or symptoms are not clear or some information missing. Stress testing is definitely not required, and the role of troponins and BNP will be limited to selected group of high risk or intermediate risk patients. So the point is, we test only if it's going to change the plan of anesthesia. Following the NSQIP, there were other tools that were also developed. One is the surgical outcome risk tool. Again, this includes more of the surgical factors that are taken into consideration. There are only 6 components, but then again, they studied only the 30-day mortality. The latest one that came up was the 2019 AUB HAS Cardiovascular Risk Index. Again, events were studied, 30-day events were studied, but it was tested in a broader spectrum of surgical subpopulation, but the actual event rate may be higher than predicted. So like I said, we have a number of tools available, but combined, there is a significant variability in the predicted risk of cardiovascular complications using all these different risk prediction tools. And the evaluated endpoints were also not consistent in all these risk groups. Every scoring system is bound to have issues like a problem of lack of calibration, diagnostic uncertainty. Even the RCRI is almost 20 years old. It is the only prospectively derived calculator, but it may underestimate the risk in major vascular surgeries. And also the CKMB was the method of assessing these patients in the post-operative period instead of using the TROP-T. According to the 2024 AHA guidelines, the risk scores have a 2A recommendations, which means the AHA recommends the use of a validated risk prediction tool like an RCRI or an NSQIP in a patient with known cardiovascular disease. Equally important is assessment of functional capacity, either in the form of a METS or a DASI questionnaire. So it is reasonable to use in patients undergoing elevated risk non-cardiac surgery. Again, the recommendation is 2A. So the whole question is as to how much of these risk tools, cardiac risk prediction tools, are we actually using in our day-to-day practice. So the use of these risk tools can definitely help us plan, modify, and even give a better quality of anesthesia to patients based on just the risk assessment tool. So I want to emphasize the importance of incorporating all these validated risk scores into our daily practice. Thank you.
So that brings us to the end of our discussion on the RCRI and the NSQIP tool. Remember, these scores don't replace our judgment, but they refine it. A good anesthesiologist is one who blends clinical sense, functional assessment, and validated tools to arrive at a balanced, defendable decision. So these scores help us enhance our own clinical judgment. And we use these indices as a part of a structured preoperative plan, and not just for risk prediction, but also for patient counseling, surgical coordination, and documentation. Up next, we shift our focus from the heart to the lungs, another major determinant of perioperative outcomes. In episode 3, we'll explore pulmonary risk scoring, particularly the ARISCAT score and the stop band questionnaire. See you next time. Bye.
Welcome back to the session, Right Words, Right Gestures, and Mastering Medical Communication. In the last session, the importance of communication skills for an anesthesiologist was highlighted. An anesthesiologist has to communicate bad news. It can be an anesthetic risk, or it can be a bad news like an adverse event which happened in the OT like cardiac arrest or death. Today, we are going to learn about collusion. What is collusion and how to handle it? If you search for the term collusion in a dictionary, you will find this definition: secret or illegal cooperation or a conspiracy in order to deceive others. But from the medical point of view, it is a secret agreement between healthcare professionals and a patient's family to withhold a serious or life-threatening diagnosis and prognosis from the patient. In short, the patient's family acts with the attending clinician to conceal a life-threatening or serious illness from the patient. Like when you try to disclose something to the patient, then it can be something like cancer, or it can be an anesthetic risk. What's the usual response from the caregivers? Oh, please don't tell about the problem to my father. He doesn't know about it. Doctor പറയണ്ട അല്ലെ, അച്ഛനൊന്നും അറിയത്തില്ല, ഇതൊക്കെ അറിഞ്ഞാൽ അച്ഛന് വിഷമാവും. So please don't tell about these things to my patient. So this is collusion. This is something every anesthesiologist is facing. And the question to the audience is whether collusion is good or bad. Is it bad? Is it good? Those who are trained in palliative care is going to give an answer like collusion is bad. Let me know from others also. So what are the arguments favoring collusion? Truth hurts. If you tell the truth to the patient, it is going to hurt the patient. Because if you tell the truth, that may take away hopes. He or she is already weak physically and may not be able to withstand the bad news. Let him or her live the rest of life with happiness, whatever is left behind. അല്ലേ, ഇതൊക്കെയായിരിക്കും യൂഷ്വൽ ആർഗ്യുമെന്റ്സ്. സത്യം ഈ അസുഖത്തിനെ കുറിച്ച് പറഞ്ഞാൽ അല്പമെങ്കിലും പ്രതീക്ഷ ഉണ്ടായിരുന്നു എൻ്റെ രോഗിക്ക്. ആ പ്രതീക്ഷ നശിച്ചു പോകും ഡോക്ടറെ. ഇപ്പോഴേ ശാരീരികമായി വളരെ വീക്കാണ്, വളരെ ക്ഷീണിച്ചിരിക്കുകയാണ്. അപ്പൊ ഇതിൻ്റെ കൂടെ ഈ ന്യൂസും കൂടെ, ഈ ഒരു ബാഡ് ന്യൂസ് കേട്ടാൽ ഒരിക്കലും അത് വിസ്റ്റാൻഡ് ചെയ്യില്ല, അത് ഉൾക്കൊള്ളാൻ പറ്റില്ല, അത് താങ്ങാൻ പറ്റില്ല. ഇനി കുറച്ച് ദിവസങ്ങളല്ലേ ഉള്ളൂ, അല്ലെങ്കിൽ കുറച്ച് ആഴ്ചകളേ ഉള്ളൂ. എന്തിനാ ഈ അസുഖത്തിനെ കുറിച്ചൊക്കെ പറഞ്ഞ് അതങ്ങ് നശിപ്പിക്കുന്നത്, ആ സന്തോഷം ഇല്ലാതാക്കുന്നത് അല്ലേ? ദീസ് ആർ ദ ആർഗ്യുമെന്റ്സ് ഫേവറിങ് collusion. These are the things the caregiver is going to tell you. Now, the question is, does collusion lead to negative impacts on patient care? See, the symptoms can worsen. When somebody is having a progressive illness, usually the symptoms are going to worsen. New symptoms are going to, happen. And when these symptoms are worsening, patient doesn't know what is happening to me, because patient doesn't know the fact that he or she is having a serious problem. So without the knowledge of the problem he or she is having, when the symptoms are piling up, the patient is not able to cope up with that. So the patient will lose confidence and patient is going to non-compliant. What is the meaning of non-compliant? Patient will not be compliant to have drugs or any type of therapy. If you're trying to get a consent for anesthesia, patient may not give. The patient may ask you, I don't have any problem. Then what is the need for surgery? Okay, so I don't have any cardiac issue. Then why should I sign the informed consent? So these are the arguments from the patient. And moreover, anger, anxiety, all these emotions can happen. And depression is another thing which is going to develop, and conflicts. The conflicts with the relatives, conflicts with the doctor and nurse. There are many points favoring collusion, and there are many negative things which is going to affect the patient care also. Now let us see what are the caregiver's feelings. How long can I hide the truth from someone who is close to me? And moreover, hiding the truth is very much distressing for the caregiver. They want to tell the truth, but they're afraid of the emotional impact on the patient. So they're not disclosing. And not disclosing or hiding the truth is a distressing thing for the caregiver. And caregiver may feel guilty for deceiving the patient. അല്ലേ? അച്ഛനോട് അല്ലെങ്കിൽ അമ്മയോട് പറയാൻ പറ്റുന്നില്ല അസുഖം എന്താണെന്ന്. അങ്ങനെ മറച്ചു വെക്കുന്നതിലൂടെ they may feel that they are deceiving. അവര് പേഷ്യന്റിനെ ചതിക്കുകയാണ്, വഞ്ചിക്കുകയാണ് എന്നൊരു തോന്നലോട് വരും. So these are the caregiver's feeling. So collusion has negative impacts on the patient and also on the caregiver. Now, again, the question is there, should we break collusion? So answer is very clear. Collusion is to be broken. But always handle with care. Because breaking collusion is a sensitive issue. You have to do it in a stepwise manner. You should be compassionate also, and you should have empathy in you while doing collusion. Now, let us see the steps in breaking the collusion. The first step is the acknowledging the patient's or the family's feelings. You have to acknowledge the presence of collusion. Okay, you can tell the caregiver that I understand that you don't want to tell or disclose the problem to your patient. I understand. I acknowledge it. Second point is acknowledge the difficulty of the situation for the relative and that he or she is closest to the patient. അല്ലേ? നിങ്ങൾ ഇങ്ങനെ പറയാതിരിക്കുന്നത് കൊണ്ട് നിങ്ങൾക്കുണ്ടാകുന്ന ബുദ്ധിമുട്ടും എനിക്ക് മനസ്സിലായി. Because you are so close to the patient and you are not able to disclose the truth to the patient, and that causes a lot of distress to you. So I understand that distress also. So two things are there. You are acknowledging there is collusion. You don't want to tell the truth. And second is, by not disclosing, you are very much distressed. And I also understand how difficult is the situation. Then you can assess the relative's understanding of the disease and impact on the family. You ask the relative how much you know about the patient's disease or patient's problem. So many a times we assume that the relative is knowing everything. It is not so. It is only an assumption. Recently, I talked to a patient's son. The patient was suffering from CAD with a very low ejection fraction and was posted for some procedure, surgical procedure. I asked the son, what do you know about your father's problem? Then he said, okay, he had chest pain and he was admitted in ICU. So I asked specifically, are you aware that your father is having a cardiac problem? Your father is having cardiac failure. Are you aware of that? Then he said no. Only thing he knew that the father had chest pain and admitted in ICU and later on discharged. So never assume. Another thing is review the reasons for not telling the patient. You can ask the caregiver. You are not disclosing the truth. Why? So naturally they may be telling you that, there is going to be emotional trauma to my father and he's already weak and he may not tolerate it. Okay. All the things which I told you earlier. And you have to acknowledge that some of these are good and come from the best of motives. See, നിങ്ങൾ പറഞ്ഞതെല്ലാം ശരിയാണ് അല്ലേ? അച്ഛന് ബുദ്ധിമുട്ടുണ്ടാവും, അച്ഛന് മാനസികമായി ബുദ്ധിമുട്ടുണ്ടാവും അല്ലെ, അച്ഛൻ ചിലപ്പോൾ അത് ടോളറേറ്റ് ചെയ്യില്ല. അതെല്ലാം ശരി തന്നെയാണ്. And that come from the best of motives. So why do you want to acknowledge the family's feelings? Now the purpose of an acknowledging is to win the confidence of the caregiver. So only if you win the confidence, you will be able to break the bad news to the patient. Okay. So this slide is very, very important. The first step is winning the confidence. I just repeat, acknowledging presence of pollution, acknowledging the difficulty of the situation for the relative, assessing the relative's understanding of the disease, reviewing the reasons for not telling the patient, and acknowledge that some of these are good and come from the strong motives. Now going to the next step, you have to explain the potential harm of, if you are not telling the patient about the disease, what can be the harm or what can be the problems. When the new symptoms are happening, when the present symptom is worsening, the patient may not be able to cope up because for him there is no disease. Now this is true. When you are trying to get an informed consent for a medical problem the patient is having, the patient is not aware of the problem, he is not giving you any consent. He will not sign the consent. So you have to tell the caregiver this fact. Then focus on the personal cost to the relative of maintaining a deception. This is also acknowledging that the personal cost to the relative of maintaining. ശരിക്കും relative പറയുന്നില്ല, so relative literally cheat ചെയ്യാണ്, അല്ലേ, വഞ്ചിക്കുകയാണ് when not disclosing the disease to the patient. So you can focus on that also and ask what the relative thinks is the patient's level of understanding. You just ask the relative, what is your understanding? What do you think about the patient's level of understanding about the disease? രോഗിക്ക് ഈ അസുഖത്തെക്കുറിച്ച് എന്തറിയാം എന്നാണ് നിങ്ങൾ വിചാരിക്കുന്നത്. So most of the time relative may tell you that, oh, he doesn't know anything. But you have to suggest that most patients would like to know the truth and that they are already aware that something serious is happening. ഒരുപാട് ടെസ്റ്റുകളൊക്കെ ചെയ്തല്ലോ, CT എടുത്തു, നീഡിൽ സൂചി വെച്ച് കുത്തിയെടുത്ത് പരിശോധിച്ചു, അല്ലേ? So patient might be knowing something serious is happening in me. Yeah. And patient might be interested to know about that also. So he is not asking because the patient loves you so much. നിങ്ങളെ വിഷമിപ്പിക്കണ്ടെന്ന് വിചാരിച്ചിട്ടാവാം പേഷ്യന്റ് നിങ്ങളോട് ഒന്നും പറയാത്തത്. And another thing which can highlight is completing unfinished business. What do you mean by unfinished business? So there are so many examples. Meeting old friends or going to some places, okay, or compromising some earlier conflicts, visiting some places of worship. So all these come under the heading of unfinished business. Only if patient is aware of his or her own problem, patient will be ready to finish this business. Okay, patient will be able to tell you what is to be done. Okay, the last but not least is you have to assure the caregiver that without your consent I will not communicate the bad news to the patient. നിങ്ങളുടെ പെർമിഷൻ ഇല്ലാതെ ഞാൻ രോഗിയോട് ഒരിക്കലും ഈ ബാഡ് ന്യൂസ് പറയത്തില്ല. This is an assurance. This is also for winning the confidence. Okay. So there are two major steps. In the first step, you try to win the confidence of the caregiver by acknowledging their feelings. And the second step, you're slowly telling them, gradually telling them in a stepwise manner, the problems of not telling the truth to the patient. To sum up, collusion is not uncommon. Patient's family is worried about the emotional impact of knowing the truth or disclosing the truth to the patient. Collusion has negative impacts on both the patient and caregiver. Compassionate, empathetic, and stepwise approach is required to break the collision. First, you have to acknowledge the family's motivation and feelings, and second, you have to explain the potential harms. And always assure the family that only with their consent, bad news will be communicated to the patient. Thank you very much. Thank you, ISA Kerala, for giving me this opportunity. Thank you.
Good evening, everyone. I'm Dr. Ramya Natesh, host for today's session. It's my pleasure to guide you all through this academic session, and I thank ISA Kerala chapter for giving me this opportunity. Hope you all have joined. After listening to two expert talks, now it's a swift change. That is the quiz session. But before we dive into the quiz session, let's take a moment to recall and celebrate the last week's winners. The first prize winner who has won the cash prize of ₹1,000 is Dr. Vikram Singh Rathore. Congratulations, Dr. Vikram Singh Rathore. He has also received an e-certificate of appreciation. Well done. And our first runner-up is Dr. Guru Sandhya. Congratulations, Dr. Guru Sandhya. She also received a certificate of appreciation. Well done. And our second runner-up is Dr. Shruti RS. Congratulations, Dr. Shruti RS, for receiving certificate of appreciation from ISA Kerala chapter. Well done, winners, and we look forward to seeing you in this today's session also. So, hope you're ready. Warm up your brain. It's all about the fastest finger, which hits the correct answer. So, let's move on to the first question. The first question is, malnutrition in children falls into which class of ASA-PS classification? Is it ASA-PS1? Option 2, ASA-PS2. Option 3, ASA-PS3. And option 4, which is not included in the ASA physical status scoring system. Malnutrition in children. Come on, everyone. Be fast. Yes, it's so quick, and the right answer is ASA Physical Status Class 3. ASA upgraded the classification in 2021, and they have included pediatrics and obstetric population as well. So in this ASA Physical Status Class 3, along with malnutrition in children, there are several other examples as well, such as the obesity, insulin-dependent diabetes mellitus, and term infant who are less than 6 weeks of age, and preterm infant who are of the post-conceptual age, less than 60 weeks of duration, etc., etc. So, hope the answer is clear for you. We'll see the scoreboard through standing first, VIDY, followed by FIDH. RASI, and VIRA. All the best. So those who are lagging behind, don't bother. We have next question coming up. All the best. So the next question, the non-verbal aspect of speech focusing on tone, pitch, volume, and speed in a communication is called as option A, paralinguistic communication, option B, metaverbal communication, option C, paraverbal communication, and option D, parasemantic communication. The non-verbal aspect of speech focusing on tone, pitch, volume, and speed in a communication. Yes, the right answer is paraverbal communication. Let's see the scoreboard. Now, yes, Guru has come up. Shru is in the first position, Guru followed by Guru, then VIDY, VRI, REKAIL. Yes, well done. Keep going, guys. The paraverbal communication is of very much importance in communicating with patients and their relatives, especially those who have listened to last class of communication. They'll be remembering how important paraverbal communication is. It has a role in relieving anxiolysis and also has several roles while handing over the patient's details to our ICU staff. Going on to the next question. The phenomenon where a region of partial block is temporarily facilitated by prior impulse, allowing a normally blocked impulse to conduct, is called option A, sense block, option B, Vedensky block, option C, Hunting effect, and option D, Hebelin block. Be quick and hit the right answer too. Yes, the answer is Vedensky block. It is also known as latent block, where there is a latent period required for the local anesthetic agent to change the function of a nerve from an unblocked state to blocked state. That is, for example, sometimes the patient can feel the skin incision, but to a lesser intensity. Hope it's clear. Well done. Moving on to the next scoreboard. That is now Guru has come up, followed by VRI, SRU, SAR, VIDY. Good going. There is a competition going on. Nice to see this. Next question coming up. The fourth question is, among the following, which carries the highest incidence for rebound pain? Which carries the highest incidence for rebound pain? Option A, intercostal nerve block, B, brachial plexus block, C, lumbar plexus block, and D, facial plane block. Which carries the highest incidence for rebound pain? Yes, it was so quick. The right answer is brachial plexus block. Rebound pain, those who are remembering or those who have able to recollect the last episode session on Blockbuster, they can know that it happens or it occurs within 12 to 24 hours after the sensory blockade has resolved. So literature has said that brachial plexus block carries highest incidence among all the blocks, probably because there is deep sensory block and the incidence ranges from 25% to 70%. Shall we move on to the scoreboard? Yes, now Guru is holding on to the first position. Yes, good. VIRE, SRU, KAIL, and ANJA. Yeah, it's a new name. Good to see you all. Next question. The last question, the fifth question is, the supporters in the coat of arms of Royal College of Anaesthetists are option A, W.T.G. Morton and Horace Wells, or is it John Snow and Joseph Thomas Clover, or August Bayer and James Young Simpson, or is it Harold Griffith and Enid Johnson? The supporters in the coat of arms of Royal College of Anaesthetists. The right answer is John Snow and Joseph Thomas Clover. The Royal College of Anaesthetists, in the coat of arms, there are several symbols which depicts the various elements in anesthesia. The cocoa seeds, the poppy seeds depicts general anesthesia, and the cocoa leaves denotes local anesthesia. And the supporters on either side of the shield are Sir John Snow and Joseph Thomas Clover, the famous pioneers in anesthesia. If you look at the picture, you can see that Clover is holding the ether inhaler and the John Snow is holding his work done with the ether anesthesia. So our questions are over. I'm also very eager to see the scoreboard, the final scoreboard. But before moving to it, we have a few comments.
I think we can proceed to the next session.
Okay, yes. So we'll proceed to the next session. I invite Dr. Sajeesh to continue with the second episode of Blockbuster.
Good evening, my dear friends, and welcome back to another episode of Blockbusters. In this series, we try to debunk the myths related to the regional anesthesia and peripheral nerve blocks. Today, we are going to discuss a myth, that is, the regional anesthesia is contraindicated in patients with coagulopathy or anticoagulation. The peripheral nerve blocks, especially under ultrasound guidance, are not absolutely contraindicated in patients on anticoagulation or with coagulopathies, but requires individualized risk assessment and strict adherence to the updated international guidelines. This risk profile for peripheral nerve block is different and generally lower than that of neuraxial, that is spinal or epidural blocks. The decision must balance bleeding risk against the patient benefit, block location, compressibility, and the type or dose of anticoagulants. We know that the spinal or epidural hematoma, that's a ventral canal hematoma, is very rare, but when it happens, it's potentially a catastrophic complication. If not diagnosed and treated within 8 to 12 hours, a paraplegia is likely. The presentation typically occurs in 24 to 48 hours after the neuraxial procedure, and the classical triad is back pain, leg weakness or paralysis, or bowel or bladder dysfunction. On the management part, the high index of suspicion, or that is the severe back pain within the 24 to 48 hours of neuraxial blockade with anticoagulants on the board, should undergo an urgent MRI and neurosurgical consultation and immediate management. And the reversal of the anticoagulants with fresh frozen plasma, prothrombin complex concentrate, or vitamin K. In case of an oral anticoagulant, some agents has got reversal agent-specific reversal agent are there. And antiplatelets, we can infuse platelets or desmopressin can give. And very important thing is that neurosurgical consultation and emergency decompression. It has to be done within 8 hours of once the symptoms has occurred. And we have to monitor the patient in ICU also. And coming to our peripheral nerve blockade hematoma, here the chance is very rare. And even if happens, the catastrophe is compared to the spinal or epidural hematoma is less. Some of the risk factors for the significant hematoma is deeper blocks like paravertebral block, sciatic or lumbar plexus block, the vascular puncture during the block placement, that is the bloody fluid in the needle hub, anticoagulations, especially the dual antitherapy, and the multiple needle passes, and not using the ultrasound and patient's movement and all. And management wise, immediately apply direct pressure for at least for 5 minutes, and postoperatively neurovascular assessment has to be done for the 24 hours and may extend to the 48 hours. Monitoring, you should watch for the increasing pain or swelling and neurological symptoms, and ultrasound, CT or other relevant investigations has to be done. And the management type, most of the time we can manage conservatively, and surgical drainage is required in selected cases. And how to proceed patient peripheral nerve blocks in a patients with anticoagulation. And before the block performing, you should take a thorough history of the anticoagulants, the patient history of anticoagulants medication, any bleeding diathesis, and any bleeding risk was there in the previous surgery. Likewise, take a detailed history. That is very, very important. And the lab investigations, the INR in case of warfarin and all other, and the APTT platelet, and that is very important thing is, and renal and liver function test has to be done. And definite block choice and procedure risk has to be selected and very well explained to the patient. Holding the anticoagulants, that is according to the latest guidelines, actually, that's ASRA and ESRA guidelines. These are the guidelines we commonly use, and that is very important to adhere with the guidelines, is that especially for the medical legal purposes and all, should be adherent with the guidelines. What are the guidelines for each drug? We will discuss after a short while. Intra procedure, use ultrasound, that minimizes the needle vascular injury and all. The post block, the monitor at least for the 48 hours, and they may extend to the 24 hours and may extend to the 48 hours. And educate the post-operative staff. That is very, very important for the red flag signs. What are the red flag signs? Shortly we will come to that. And resume anticoagulants once the hemostasis has confirmed. So what are the red flag signs and patients on anticoagulations? And the important concept you should follow is that, and the protocol you have to follow is that regardless of the anticoagulant, whether the patient is on anticoagulant or not, all the patients after the peripheral nerve block has to be monitored for the signs of hematoma formation. They are the severe or increasing pain at the block site, swelling or palpable mass, induration or bruising, neurological deficit hematoma is compressing the nerve. That can happen, they can produce a prolonged blockade, new weakness or numbness. And signs of hypovolemia like tachycardia and hypotension, that is especially in interfacial plane blocks like rectospinal plane block and all, maybe there may be a hidden bleeding risk there. And what are the types of blocks and risk of hematoma formation? The superficial, that like axillary, femoral, popliteal and has got a low risk. The importance is that these are compressible sites and easy to monitor, and even any hematoma they are easy to decompress also. The facial plane blocks like TAP or QL and all has got an intermediate risk, as the risk increases with anticoagulation and the depth as we go more deep. Deeper blocks like lumbar plexus, infraclavicular, deep sciatic and all high risk there. They are in the non-compressible site. And of course, neuroaxial has got the highest. And some of the surgeries like neurosurgery and hip revision surgery and prostate URP and all has got a more bleeding potential there. And let us discuss some of the commonly used anticoagulants, timing for the regional anesthesia, and when to stop prior to spinal anesthesia or epidural, when to stop prior to the peripheral nerve block superficial, and when to stop peripheral nerve blocks, the deeper blocks, and when to remove the catheter and restart drugs after catheter. And we will be discussing about the when to stop before peripheral nerve blocks like superficial and deep. And the general idea is that the deep blocks has got a similar, almost a similar recommendation to the same as the neuraxial blockade. Aspirin, of course, we know no requirement and is not required. The stoppage is not required, and clopidogrel and other drugs like ticagrelor and all has got a 5 to 7 days stoppage time. And it's not catheter. Some guidelines is not recommend the catheter insertion, and some guidelines say it's around after only. Even if you are putting the catheter, it has to be after 7 days of stopping the drug. And warfarin, the current concept is that the INR should be in a deeper superficial or a catheter removal or all the procedures, the INR should be less than 1.5. Low molecular weight heparin, the prophylactic dose is stopped, especially the deeper blocks around 12 hours prior to the deeper block, and the therapeutic is 24-hour, and we can remove the catheter 12-hour in a prophylactic and 24-hour after the therapeutic dose. Unfractionated heparin is 4 to 6 hours, and you can restart after 1 hour after the catheter removal. Dabigatran, rivaroxaban, and apixaban all normally around 3 days we have to stop, 3 days prior to that. And superficial blocks we can perform within 48 hours, that's 2 days. And 24 hours after the last dose we can remove the catheter, and 6 hours after we can restart. Fondaparinux is another tricky anticoagulant. Here normally the 4 days prior to that we have to stop before the block, and renal impairment and all, it will be prolonged, and no catheter is recommended in these patients. And thrombolytic like alteplase and streptokinase on acute coronary syndrome patients. The ideal is around only 10 days after the stoppage of thrombolytic we are allowed to perform the regional blocks. But at least like in a superficial blocks, we require a superficial block in a compressible site, and we can do it in 2 to 3 days. But should remember that patient is already thrombolized because of an acute coronary event and all. The hemodynamic instability is there, so you should be very careful. No catheter is recommended here. So the some of the myths regarding the peripheral nerve blocks and anticoagulation. Warfarin 1.5 to 2 is safe. No, the current recommendation should be less than 1.5. Peripheral nerve block and bleeding risk is negligible. It is applicable to the superficial blocks only. The deeper blocks has got higher bleeding risk in deeper blocks, even though the peripheral nerve blocks, deeper peripheral nerve blocks, higher risk there. And oral agents should be bridged with heparin. No need of that. Current recommendation does not say like that. All anticoagulants must stop before regional anesthesia. No, we already discussed about the different anticoagulants and its duration at which we have to stop, and we have to remove the catheter, and when we can start on and all. That is depending upon the agent and type of surgery and type of block we adapt. Bloody tap means abandon the procedure. No, that indicates that already some bleeding occurred and the multiple injection, the risk of multiple injection also there. Ultrasound eliminates anticoagulation concern. Ultrasound reduces the chance of vascular puncture, but that does not eliminate the anticoagulation concern. So to conclude, the superficial blocks, they are compressible and accessible, and it's less risky. So the stringent restriction is not needed in the superficial blocks. Deeper blocks are non-compressible site, and the risk of major bleeding is there, and almost the timing is same as the neuraxial guidelines. Ultrasound guidance, of course, that reduces the chance of vascular puncture, does not substitute for anticoagulation management. Catheter removal often carries the same or higher risk as insertion. So, never remove a catheter during a therapeutic peak anticoagulation. So, another important thing is that whenever we are in doubt of any anticoagulation, when to stop and all, around 3 to 5 times of its half-life, you have to wait for that. And of course, then the patient is on renal function abnormal creatinine clearance and should be very careful on that. And the timing varies between individual patients depending upon the clearance, age, and renal function and clinical context, because most of the anticoagulants that are eliminated through the kidney. So the creatinine clearance is very important. Always consult most recent guidelines, and the patient specific and agent specific recommendation has to, you have to adhere with the guidelines and recommendations. This is very important for the medical legal purpose and of course the safety of the patient. And when in doubt, don't do it. Weigh the merits and demerits of the bleeding complications and select the blocks accordingly. So if there is any concern of the bleeding, alternate anesthetic plans should be adopted. And always is safer is a superficial block where it is compressible. And common major references: American Society of Regional Anesthesia, 5th edition, that's 2025, and European Journal, European Society of Anesthesia Guidelines in 2022, and Society of British Anesthetists in 2020 are the major guidelines, and these are some of the references. And thank you very much, and we will meet next week with another myth related to the regional anesthesia and peripheral nerve blocks. Good night.
It was well past midnight in a quiet operating room in southern China. The day's cases were long over, the corridor silent, except for the faint hum of the anesthesia machines. When the nursing staff opened the doctor's locker room, they did not expect to find someone still there, motionless, pale, with the soaked gauze still pressed against his face. The scent was oddly familiar and unmistakable, sweet, fruity, and comforting, the same scent that had lulled thousands of patients to sleep. But tonight, it almost claimed the doctor who delivered it. He was just 28, a young anesthesiologist, calm, meticulous, and diligent. He had induced dreams for so many others before. So what dream was he chasing tonight? Or perhaps what led to such a mishap? Tonight, we explore the story behind an interesting case report published in 2018 in China by Luo et al., titled Sevoflurane Addiction Due to Workplace Exposure. I am Devi Padmakumar, and this is the Anesthesia Chronicles, where we discuss stories that truly matter in all walks of anesthesia. So to understand the story, we must travel back in time to the roots of anesthesia itself. When ether and chloroform was first introduced in 1840s, their effects fascinated physicians as much as it relieved patients. Early pioneers such as Sir James Young Simpson famously inhaled chloroform at his home, the effect of which he described as soothing and delightful. In those days, anesthetic experimentation was not just accepted, it was expected. By the 20th century, the pharmacology of anesthetic agents had advanced. But curiosity remained, and so did access to such drugs. Anesthesiologists worked with substances that could transform consciousness within seconds. By the 1960s and 1970s, first published reports of self-administration appeared. Halothane, ether, and even nitrous oxide. Some did it to relieve stress, others out of curiosity, and many actually thought they could control it. By then, synthetic opioids entered the scene. Fentanyl, introduced in 1960s, was a revolutionary drug, fast-acting, smooth, and clean. The first fatal cases of fentanyl misuse among anesthesiologists appeared in the late 1970s. By the 1980s, medical literature was full of tragic deaths. It became painfully clear that the field of anesthesiology carried an extraordinary risk of addiction. A landmark study in 1992 by the Mayo Clinic showed that anesthesiology trainees were overrepresented among physicians with substance use disorders. Subsequent studies across North America and Europe confirmed that anesthesiologists were 2 to 5 times more likely to develop drug dependence compared to other specialties like psychiatry. The reasons were systemic: a constant access to controlled substances, profound knowledge of their pharmacology, high occupational stress and sleep deprivation, and a workplace culture that valued composure over vulnerability. By the late 1990s, newer agents brought newer problems. Propofol, once hailed for its safety, became a drug of misuse, offering instant euphoria and sedation. As the new millennium began, the medical community started asking the difficult question: what if addiction among anesthesiologists was not a moral failing, but a form of occupational hazard in itself? So before we go into the case report of interest, can anyone guess what the substance that the anesthesiologist was addicted to in our case? Please comment your answers below. In 2018, Luo et al. Published a case that gained global attention. It was published in the International Journal of Environmental Research and Public Health, titled Sevoflurane Addiction Due to Workplace Exposure. The subject is a 28-year-old anesthesiologist with 4 years of working experience. He was often described as hardworking, calm, quiet, and composed. He often stayed late after surgeries, tidying up, checking equipments, or finishing up documentation. With no prior experience with addictive substances such as alcohol or nicotine, the patient had tried inhaling anesthetic sevoflurane 1 year previously. He referred to novelty seeking and treating insomnia as his main motives. Sevoflurane, in a dose range of 3 to 5 ml via sniffing with gauze, resulted in a few minutes of cloudy euphoric relaxation, the effect of which he enjoyed. He eventually increased the dose from 6 to 8 ml to induce sleep after work. He admitted to sevoflurane misuse and claimed a sleep disorder as an excuse after he was found admitted with aspiration pneumonia. After 4 months of standardized treatment, he returned to work. However, 3 weeks later, he took sevoflurane again because he could not stand secondhand sevoflurane from patients with general anesthesia in the ambient air of the operation theatre. His most powerful cues for a second relapse was secondhand exposure to sevoflurane and an easy access to sevoflurane container. So on the nights that his colleagues had found him unconscious in the locker room, he had covered his face with a gauze soaked in high concentrations of sevoflurane. A bottle of liquid sevoflurane lay beside him. He could not be awakened and was found to be addicted to sevoflurane for a second time. His superiors mandated inpatient admission for immediate detoxification from sevoflurane. After 4 months of rehabilitation, however, the patient was advised to pursue another medical career outside anesthesiology due to his intense sensitivity to sevoflurane and high risk for relapse. So the report claimed that although identification of responsible factors remains difficult, workplace exposure can increase the risk tenfold, especially in anesthesiologists with genetic vulnerability to anesthetics of abuse, as with the case of all addicts. The author also enunciates that the safety of operating room personnel should cause widespread social concern. Chronic exposure to second-hand anesthetics discharged from patients and anesthesia breathing circuits could endanger operating room staff. Effluent gas with a high concentration of anesthetics was directly discharged without treatment into most operating rooms, leading staff to experience dizziness, headache, and fatigue after they spent a typical workday in the operating room. The case report recommends effective ventilating systems should be installed in all operating rooms, and the quality of surgical setting may need to be addressed. So the authors concluded that chronic low-dose workplace exposure could have predisposed him to this addiction, along with certain genetic factors. Luo's case was a wake-up call, but it wasn't isolated. In the years since, similar incidents have been reported in the US, the Europe, and South America, documenting the misuse of sevoflurane, nitrous oxide, and desflurane. But why? Partly because of their easy access. Vaporizers left connected in theaters with minimal accountability, unlike narcotics. And partly because of their immediate effects of euphoria, disinhibition, and sedation without the use of needles and paperwork, unlike opioids. It's an invisible addiction. No syringes, no paperwork, no signs. But let's address the elephant in the room. Addiction, the silent killer among anesthesiologists. In India, the problem exists, often unspoken. Small surveys among residents and consultants reveal instances of propofol, fentanyl, and benzodiazepine misuse, and rare cases involving inhaled anesthetic agents. High workloads, night duties, and constant pressure to perform compound the risk. Unlike in some Western systems, India still lacks formal physician health programs where early intervention and rehabilitation replace punishment and stigma. Fortunately, the dialogue is shifting. Many national societies and teaching hospitals have included sessions on mental health, substance misuse, and burnout. To my dear young anesthesiologists who are listening, remember this. Knowing a drug intimately does not make you immune to them. Respect every agent that you touch. Guard your well-being with the same vigilance that you would guard a patient's airway. Lean on your colleagues, check in with your friends, and ask them how they're doing before the silence quietly sets in. Because in the end, the goal of anesthesia has never been just to keep others asleep. It's to make sure we stay awake too. This is the Anesthesia Chronicles. Until next time we meet with an interesting story, stay calm, stay awake, and stay human. Now for our final question. Drop the first thought that comes to your mind in the comment box.
Yes, with that insightful expert talk, now it's time for the next segment. The most awaiting moment, that is the announcement of results. Let's see who's on the spotlight. Yes. As you all can see, Guru is on the first position, who's going to receive our cash prize of ₹1,000 by ISA Kerala chapter. And our first runner-up is VIRE. Congratulations. And our second runner-up is KAIL. So congratulations, many congratulations. You will be receiving your e-certificates, and the first prize winner will be receiving your cash prize quickly.
It's fantastic
And
because we'll take some more time to decode who is Guru, whether it is Dr. Guru Sandhya, who was the previous winner. Very probably maybe Virendra, I don't know. And maybe next episode we'll announce the winners. We'll contact the winners and announce it during the next Anesthesia Connect session.
okay, sir. I'll invite Dr. Sanish PG for delivering vote of thanks.
Okay. Thank you very much, Dr. Ramya. It has been a fantastic episode. Dr. Binil is also with us, the leading force behind Anesthesia Connect by ISA Kerala State Chapter President. I also thank the constant support and encouragement by Dr. Vijish Venugopal, the Honorary Secretary of ISA Kerala State Chapter, Dr. Rajesh MC and Dr. Sajish for their wonderful contribution and encouragement in their respective places. Of course, I need to special mention of all the faculty panelists, including Dr. Ashu Saramathai and the team from Believers Church Medical College, the ever-loved Dr. Babraj with our communication skills series, Dr. Sajish Gopalan with our Mythbuster or Blockbuster in regional anesthesia, and the youngster Dr. Devi Padmakumar, who always surprises us with some or other chronicles from anesthesia. Of course, special thanks to Dr. Ramya Nadesh, consultant and Anandaburi Hospital, Trivandrum, for conducting today's quiz in a fantastic manner. We look forward to finding out the winners, and we'll be transferring the cash prize and the e-certificate of appreciation from ISA Kerala very soon. Dr. Binil, any closing remarks? Yes.
Yeah. Thank you, Dr. Sanish. An excellent talk by all the four speakers, Dr. Ashu Mathai and team, Dr. Sajish Ji, Dr. Babraj, and of course, Dr. Devi Padmagar surprised us. And it was an excellent, wonderful quiz time by Dr. Ramya. Thank you all, and it was a very good addition from ISA Kerala State Chapter. And see you all.
I think we should also remind our viewers regarding the WhatsApp group.
Yeah,
Yes,
we
Anesthesia
got
Connect WhatsApp group is there.
We got ISA Kerala Connect, ISA Kerala Connect, Anesthesia Connect WhatsApp groups. To join Anesthesia WhatsApp group, you can contact anyone of us. Either you can contact me in my phone number, or Dr. Sanish, or our secretary, Dr. Vijish. So we'll be sending the link to you also. You can join through link also. So we will be sharing all our documents and study materials through the WhatsApp groups. Also, I
The
request you
invitation link is
follow.
given in the description.
You already sent. Okay, good. And also, I request all of you to follow us on Instagram page. We need more followers to start our streaming. So see you all next week, same time, Saturday, 7 p.m. Thank you and good night.